and only mode.
CCPR doesn't stop.
Okay, so this is Jennifer. Okay, let's go ahead and get started.
So is it recording? It's recording. Okay. Hello, everyone. Thank you very much. And hello to our mainland audience who has been waiting patiently. Thank you. Okay. So we're going to be starting our panel on success stories in environmental change, which impact NCD control in Hawaii and the Pacific. Okay. So at this time, I'd like to call upon our moderator. I'd like to introduce her. So Krista Hodges is a cancer epidemiologist with the Hawaii State Department of Health. She also lectures at the University of Hawaii and teaches social sciences. And we're very happy that Krista can be here, and she's also been helping with the planning of this symposium. So let's give a hand. Thank you. This is the one that's recording on screen.
You said there was a speaker's introduction or script. Okay, good morning. Our first lecture or first presenter is Jennifer Ryan, who is a school health coordinator with the Hawaii State Department of Health. Jennifer Ryan is a, can't hear anything. How do I turn this thing on?
It should be on. Just speak directly into it.
Got to get closer.
Color is the light. Yeah, it's on.
Okay, I guess
There you go.
I can hear it now too. Sorry about that. Our first panelist is Jennifer Ryan, school health coordinator, Hawaii State Department of Health. Jennifer Ryan is a school health coordinator, member of Hawaii Farm to School and School Garden Hui, representing the Department of Health's Healthy Hawaii Initiative. Hawaii School Gardens aims to bring together the public, private, and community agencies for a healthier Hawaii through garden or school garden projects. Let's all welcome Jennifer.
Good morning, everybody. My name is Jennifer Ryan. I'm the School Health Coordinator for the Hawaii State Department of Health. Thanks for being here today, and thank you for inviting me to come speak with you. I'm really excited to talk with you about primary prevention. I know a lot of what you've been talking about is health disparities, and we know that environmental systems and policy approaches are a really great way to look at the system to support good health. So I'm going to talk about wellness in schools. And before I do that, I want you to also know that I am the representative, but it's really a team-based effort. So,
Oh, it's for the webinar. You need to put it on the
oh, okay. Sorry, technology. So it's part of a wellness. I am part of a wellness team. Department of Health works very closely with Department of Education for the implementation of student health policies. We also work with University of Hawaii for support of data collection, evaluation, and implementation of our programs. So I'm not sure how to navigate. Is it? Okay. So a little context, we know that nearly 2/3 of cancer deaths in Hawaii can be linked to 3 lifestyle factors: tobacco, poor diet, and lack of physical activity. So I know that you probably got a lot of background information about adults and demographics in Hawaii. If you didn't know them already, I thought it might be interesting for you to have some information about our youth. We coordinate the Youth Risk Behavior Survey, which goes out every other year in schools. Excuse me. The Hawaii Public Schools. And so, whoops. And so, this gives you some context of who are our youth today. We know that about 10% of our youth are smokers. We know that only 10%, 9 really, are eating their recommended amounts of fruits and vegetables. So that means we have 90% of our students to help with nutrition. As far as physical activity goes, only about 1/5 are achieving the 60 minutes a day of recommended physical activity. So these are the 3 things that we want to make sure that we address through policy. The Hawaii Department of Education is unique in the United States. We are the only statewide public school district that has a lot of advantages. It has some challenges. We're the 10th largest district in the nation. It consists of 7 islands, so we do, in fact, have a school on Nihiau. And the regular public schools are 254 this year. It's over 170,000 students. And as far as school food services go, they serve over 100,000 meals every single day. That's breakfast and lunch. Department of Education Wellness Guidelines. How did this policy evolve? Well, back in 2004, the USDA required any school food authority that is receiving federal funds to develop a local wellness policy. So I imagine that this is similar across the Pacific. Anyone who has National School Lunch Program has to have a wellness policy in place. That was great. We knew that this was probably going to be coming down the line through other legislative initiatives, so we were ready to jump on board. The Board of Education created a kind of a framework for the policy in 2006, and then in 2007, through a stakeholder collaboration, we really rolled out the wellness guidelines. So as far as the actual development of the guidelines went, we had DOH, DOE, we had community organizations, we had university members, we had parents. We invited students, but it was during the school day, and so they weren't able to attend. But we made sure that we tried to get as broad as possible support for the creation of the guidelines. As a result, they've been recognized as some of the most comprehensive guidelines in the nation. What are the different components? Well, you can see here, the first one is a school committee, because while we have an overarching state policy, we want it to be locally driven. So every school is encouraged to create their own committee so that while they have this as the baseline, they can change the guidelines to go deeper according to the needs. There's nutrition standards for all food and beverages sold or provided to students, not just during the school day, but at all school-sponsored events. Nutrition and health education, we have this built in so that there are required minutes of instruction for health education, and nutrition is integrated into a wide range of topic areas. For physical activity and PE, we have, again, required minutes of instruction. We also have requirements for providing information to families about physical activity opportunities outside of school. One of the things in our physical activity piece that most people don't recognize is essential is recess. We have 20 minutes of recess required every day for students. And we know that there are competing priorities for that time, and sometimes that is compromised. But this is very important for the students to just get up and get moving during the school day. Sometimes it's their only opportunity. Professional development. We wanted to make sure that all staff members, not just teachers, are involved in a wellness approach. So really looking at the coordinated school health model, engaging counselors, engaging the cafeteria. Maybe it's working with custodians, because sometimes those are the backbone people who make things happen in the school. So I wanted to go over what are some of the changes, what has happened in the school environment. School meals, like I said, it's huge. If we want to reach the majority of our youth, ages 5 to 17, we're going to affect their nutrition through the meals program. So milk, 5 years ago maybe more, we switched. All of our milk is either skim or 1%. We still have chocolate, but the sugar has been reduced in the last 2 years to meet IOM standards, which is also great. So we're encouraging them to drink milk in order to meet their calcium and other nutrient needs. All rice and all baked goods are now 50% or more whole grain. This was a huge change, and I'm sure it is in most of your families and your communities. When you have brown rice on the plate, people notice. And so we had parents saying, there's no way my child is ever going to eat brown rice. We don't serve it at home. They don't like it. And then we talk with them a little bit more and let them know that actually their child's been eating brown rice for the last 3 years. You just have to make the changes slowly. So like I said, the baked goods too, the salads, and you might know that USDA is making a really big push towards incorporation of more types of vegetables into the meal program. Our first change was to go with green leafy veggies and not just iceberg lettuce in the salads. Now they're also required to have red and orange vegetables, beans, and I guess the fourth category is starchy, but we're de-emphasizing the starchy vegetables now. There are 0 trans fats in all foods, and this is also for the foods and beverages provided outside of the meals program, and 15 of our entrees are made from scratch. So a lot of school districts, they just have heat and serve. In Hawaii, we have bakers. They actually prepare the food in the cafeteria. This is just a model of one of the environmental changes. It went from cafeteria to dining center. They even have a DJ program. Change in vending. We only have vending machines in schools with water. They're allowed to have 100% juice, non-fat, or skim milk because of the shelf life issues. Most of the vendors have not gone with those options. We have no food vending in our schools at all. Curriculum and instruction. So what's balancing out the school food environment is instruction in the classroom. We really want to reinforce those messages. So Department of Health funds 9 health and PE resource teachers, 1 for every district. We have PDE 3 courses, which is intensive professional development. It's usually a 6-week course. This provides opportunities for the teachers to get credit towards their credential. And so they're interested and they're learning more about health and PE because a lot of our, especially elementary teachers, don't have that content expertise. They're expected to teach social studies and science and math and art and PE, but they don't always have that preparation in school. We do district level trainings. We have a fitness meet, just happened in Windward District last week. There were probably over 500 students and family members at our Windward District fitness meet. We have model schools now for health and PE. There are lending libraries. So the lending library is not just books, because we're talking about PE and health and then the move towards project-based learning. Our lending library has things like trikes and Indo boards and plastic food models. So when a school wants to do a special unit, they can borrow the kit, use it for a week, and then give it back so another school can use it. We also have an annual conference in conjunction with Hoppard. Here's another example. These are the trikes. Kids love these. They're self-propelled. And the teacher, I don't know if you notice, some of the things that are different in this picture, the teacher has all of the students engaged. Nobody's waiting on this side. Nobody's worried about their turn or whether or not they're going to be picked. They just get on and get moving. The safety and wellness survey. How are we monitoring compliance with this with the wellness policy? We have an annual survey that's given to principals once a year. And it measures compliance, but we also have some items in there that are useful for evaluation. We want to know what are the barriers, what are the facilitators. We use this data in order to generate reports for the superintendent's annual report, which has select indicators. There's also a new longitudinal data system. So the Department of Education wants to track over time, how are students doing academically? How are they doing with discipline? What about attendance? And we are also incorporating school level data there to see maybe is there a connection between those schools that are more likely to meet the wellness guidelines and the ones with the highest rates of attendance or fewest sick room visits or higher test scores. So the superintendent's annual report, I wanted to give you kind of the baseline. Where are we as a state? In 2010-11, we had all of our schools responding to this survey. 80% of them approximately had a wellness committee at the school level. 40% are meeting this requirement for foods and beverages. We know that that's a sticking point. We know that the least compliant source of food and beverages is athletic concessions. And so we're working with the athletic directors to address that situation. We also know that parties are a challenge. So what happens when it's a birthday? Cupcakes, ice cream, candy. But those are all things that have been social norms, right? They're all positive reinforcements for junk food. So we're changing that. We want to encourage the parents, bring in a story, do extra minutes of physical activity, find ways that it can be a healthy celebration. PE and health are about the similar. They're more likely to be meeting PE. And then again, the 20 minutes of active recess. So overall, we're at about 78%. Hot off the presses is this book. I brought some samples for you. It's a report of all the wellness guidelines. Superintendent's report only has these 5. And it's all available online. So on the very first slide, for instance, there's a website. I don't know if you have access to the presentations, but if you want any more information, including a copy of this report, you can go to the website on the first page. I already told you about some of the challenges. Number 1 and 2, time and money. Not a big surprise there, right? With Race to the Top funding in Hawaii schools and No Child Left Behind, I think you probably all know that schools are under a lot of pressure to perform on academic achievement tests. But for the financial part, tobacco settlement in Hawaii has been used for primary prevention projects, and in particular with the relationship between Department of Health and Department of Education. So that's why we are able to provide funds to schools for teachers. Low school meals participation in upper grades. We know that over 80, close to 90% of children in elementary school are participating in school meal programs. High school, it goes down below 20%. Kids who participate in the school meals program are more likely to be meeting nutrient intake than the students who bring their lunch from home or choose other food sources. So we really want them to eat what is provided in the meals program. Like I said, these are kind of the sticking points. I forgot about fundraisers. So yeah, Zippy's chili, America's Finest chocolate, sausage. It goes on and on and on. What are you, like the bake sale, right? It's iconic. Who can guess what the number 1 fundraiser is in Hawaii? Like the largest grossing return on investment. Any ideas? Girl Scout cookies? Nope. Krispy Kreme? No. Honey's bread. You know, most people think of food, but actually it's fun runs. Fun runs are the largest grossing activity. It requires no food at all. And I think the largest one that I know of about was like a $40,000 fun run. And it's because they can get sometimes community sponsorships, networking with businesses, in addition to the families that are already overburdened with the cost. So this is kind of a summary of the wellness system. We have a policy in place. We have a lot of supports through the online toolkit, local committees, professional development. Then we see the positive consequences so that it supports each other and monitoring. So that's kind of a summary of everything, but if you have any more questions, please get in touch with me. My contact information is in your materials, and I brought some samples for you. I'll put them on the table outside of materials. This one is on healthy schools, when we gave schools money to see what they wanted to do. We put their samples in here. School gardens was one of the main ones. And then also the recess before lunch policy, which is a free policy change. It's just about having time for play before the kids eat. So thank you, everyone.
Okay, we will be doing questions after all the presentations. Thank you. Okay, thank you very much. Ms. Joanne Ogo from the Regional Cancer Center Registry, Commonwealth of Northern Mariana Islands will be next. Ms. Ogo has been a member of the CNMI Commonwealth Cancer Coalition since its inception. With a background in mobilizing youth, Joanne has served as a CNMI Comprehensive Cancer Control Coordinator for 5 years. She is presently the CNMI Cancer Registrar, but remains active in a myriad of cancer and NCD control efforts to improve the health of the citizens of the CNMI. Welcome, Ms. Ogo.
Hi, good morning. Okay, so I know that on the form it actually says John Gonzalez, so I'm the new John Gonzalez for the day. He sends his what do you call this thing? Apologies in regards to not being able to be here today for the fact that he has a medical emergency that he needs to attend to at home. So I'm standing here on his behalf. I apologize in advance. I saw this presentation 2 days ago, but I was busy with my training, so I haven't really gone through it, so spare me. Okay, so we're going to talk about NCDs in the CNMI. NCDs in the CNMI is such a big burden. Um, and the preceding slides after this would actually touch on what happens in the CNMI or how we came about with our projects at the end of the slides. Okay. So causes of NCDs are the number one, or sorry, so what's listed up here is the causes of NCDs, and basically at home, you know, we hardly walk around anymore. There's just too much, the cars are there, you know, there's caller rights now that is available for some people, and so we forget about the whole aspect of, sorry, okay, forget about the whole aspect of taking a few minutes off of your busy schedule to go out and walk. But we really do have accessible pathways around the villages, around the islands. Traditional leaders, we really we need our elected officials to come out and support us. Some of them do come out and support, and others, they will support us by introducing the bills, but not really practicing what they're trying to accomplish with us as a group. Everything becomes, okay, so the healthier options are really expensive for us to choose, and with our economic financial crisis that we're going through back home, it makes it really difficult for us to actually purchase healthier food options. And so it leads to the risk factors of NCDs, leading on to the intermediate risk of, you know, having high blood pressure, high sugar, abnormal lipids, and overweight, obesity, right? Through that. So it's a chain. So you see the arrow going that way. We need it to come this way so that we try and stay healthier. You know, we develop heart disease, cancer, stroke, diabetes, COPD. The pictures on the bottom kind of just addresses, you know, we forget how to walk, use the car, we eat all these unhealthy diets, and then we get on the scale, we see we're obese, and so forth, and then that's the effect of it. So they did a 2009 research, or through the Vital Statistics Office, and it showed that in 2009, 7 out of every 10 deaths in a matter of 3 months was NCD related. And so as we say, we NCD Bureau, the newly organized NCD Bureau, we're now sending our messages out, and we're not saying it's a cancer thing or a diabetes thing. It's now an NCD approach. And so all our ads from here on out has the eat healthy, be physically active, and stay tobacco free, or be tobacco free. Okay, so basically this slide just shows how the breakdown for this one. So in 2010, based on the Vital Statistics Office, we have cancer as the top leading cause of death in the CNMI. 23 deaths were recorded in 2010 for cancer, 21 for disease of the heart, 19 for stroke, 16 for pneumonia, and sepsis 11. In 2012, we did an analysis up at the dialysis unit, and for those of you who didn't know, it's not nothing nice to say, but we're saying, there's that message saying we have this new dialysis center. Um, it's not a good thing. We have the dialysis center up and running, and so we did an analysis, and there's now 96 patients being seen at this dialysis unit. And this does not include the dialysis unit over at the St. Jude Renal Care, and that's a privately owned renal facility. Of those, in 2011, we have 15 Chamorros, 7 Carolinians, and 2 Filipinos who are currently receiving dialysis treatment. Um, so this next few slides are basically the ages of patients that we have. So as you see, we have 32 patients, the age of 50 to 59 years old. We normally, our people now survive to like 54. We're lucky if they reach the nice ripe age of 80 to 90. But a lot of them have been passing on due to NCDs at like the age of 52 or 54. Again, another slide between 2009 to 2011. 2009, we had 18, a jump to 23 in 2010, and a jump in 2011 to 27. So we were getting tired of all these reports, right? And then we find out that we have childhood obesity. 45% of 7 to 10-year-olds are obese or overweight. What did we do? What did public health do? Public health decided to go with the First Lady Michelle Obama's initiative, and we wanted to get out and let's move CNMI. So for the whole month, for January 2012, we were at a planning stage in developing a Let's Move Marianas campaign. What we did in 2012 September, we kicked off the Let's Move Marianas campaign. And with that Let's Move Marianas campaign, we had all the schools participation, one whole day just focused on going out there using the track and field. So we partnered with the Sports Recreation Center. We partnered with the schools. We partnered with nonprofit organizations to help us move this throughout that whole day. And this was a 5 a.m. to 3 p.m. activity in which the whole time you see kids and parents moving around. At exactly 10 o'clock in the morning, all the activities halted. We were all called to the middle, and we did Beyonce's music. It's even live on YouTube. We organized a mock show. We just came out because we were practicing all through that time we were organizing. And we just had this nice dance, and everybody joined in. And you have these different age groups just coming in and doing a mop show, and then another one just jumping in. So we kind of brought that all in together. Did that stop? Did that stop after that? No, it didn't. Immediately after that, we developed or we partnered with the Get Fit CNMI. And the Get Fit CNMI is a private organization that addresses overweight, obesity, and just promoting a healthier lifestyle. So we did a pilot project based on the CCC project, one of our CCC project goals. So we did a physical activity pilot project, and we started off with public health because what we always say is we need to be good examples of what we're trying to tell the community. So we started off at public health. A few public health program staff went in, got weighed in, and took their body mass, everything, and we started a 3-month Get Fit CNMI with the Get Fit CNMI team. And our NCD administrator, Ms. Jocelyn Songsong, who couldn't be with us today, was a part of that group, and she lost 23 pounds in that short span of time that she was doing it. But it wasn't because she wanted to lose that weight. She wanted to start that example for the staff, for public health. And so we used her, and um, we made it look, made it realistic that anybody could do it. So that pilot project has ended, but those that are in it are still continuing to go on. It didn't stop with only physical activity. They started to do their a healthier food choices. So instead of opening a can of spam or a can of corned beef now, they eat only what they can hunt. And that's the whole thing, is going out there and hunting. So root crops, no more rice, root crops, garden vegetables that are just grown outside. So nothing with sugar. So she even turned around, and she's no longer taking any sugary food or drinks. So she's done a totally complete change of her lifestyle. Her and a few of the public health staff. Through that also, we did not just stop the project there. We extended it out to Rhoda and Tinian. And so now Rhoda and Tinian hold their own. But again, our project didn't stop there. Now we have what's called the Marana's Health Walk. The Marana's Health Walk involves all government offices coming out, and the governor has supported this. All government offices and private sectors are invited, schools, to come out and join us for a 1-hour walk at the Beach Road Pathway. Thank you. Oh. Thank you.
Excellent. Thanks. Okay, next we have sorry, I'm going to kill names. Edolam Ikardu, Comprehensive Cancer Control Program Coordinator from the Ministry of Health, Republic of Palau. He's Edolam, sorry, Ikardu, I'm sorry. I'm so sorry. I mess up my name sometimes. E. Is the Comprehensive Cancer Control Coordinator for the Republic of Palau's Ministry of Health. Has done comprehensive work on the worksite wellness and sustainability of successful project implementations and getting community involvement going. Thank you very much.
This is for the webinar. We need to put on a shirt. Oh, that's for the webinar. So yeah. Is that good? Alrighty then. Don't worry about it. My Ponapian counterpart, every time she says my name, it actually means your mama in Palawan. So at least you weren't cussing me. Okay, my name is Adol Igardeo, and I'll be talking about one of the environmental strategies that was implemented maybe 5 to 8 years ago. Actually, it's not really a physical or a material change per se, so I put quotation marks on my environmental, but it might be a catalyst leading up to more permanent PSE changes. Dr. Lam told me that the first 2 slides were to show the NCD burden in Palau, so I wanted to count our blessings before doing so. As some of you might know, in December, we had the threat of Typhoon Bofa, Super Typhoon Bofa, and missed us. But like some of you Pacific nations, we constantly face the threats of natural disasters. But we were lucky, it missed us, most of us. And then we have about 20,000 very beautiful people, and not just Palauans. About a third of us or a fourth of us come from other islands, including the Philippines, and we have Dr. Dever also. We also have an evolving culture. We embrace the many cultures that have come into contact with the Palau people. And so these are the same people, but to the top left, we have the first birth ceremony. And then down below, a year later, we have sort of a Western first birthday celebration. And then, of course, we have many resources on land and in the sea. But of course, we have those imported goods that are coming in at a rate that we should be scared of than BOFA or Sudal or Evan. So despite all these blessings that we have, the NCD burden in Palau, like most of you guys, we have an epidemic. The three leading causes of death: heart disease, cancer, respiratory illnesses. 8 out of 10 deaths are related to NCDs. I borrowed this slide from Dr. Cuarte, our former minister. 55% of the budget from Ministry of Health is spent on NCDs, and it doesn't include absenteeism or function loss. More than 80% of all off-island medical referral are NCD related. So those that go to Tripler, the Philippines, and Taiwan. A third of our school-aged children are obese or overweight, and more than half of high school students use tobacco. This is reportedly the highest in the region. And obviously, we're the 7th obese country in the world. According to ER logs and public safety records, the level of injuries and death due to violence have increased. This is also a borrowed slide from Dr. Cuarte, an adoption of showing the conditions and diseases, chronic diseases and conditions. So it just shows 8 of the most common NCDs and conditions in Palau, showing the relationship with the risk factors. Of course, on the right, obesity contributes to 7 out of the 8 NCDs and conditions. So it's not really a surprise that one of the strategies would be related to physical activity. About 5 to 8 years ago, as I said, there was a 5-day strategic planning that took place at Palasia Hotel, for those of you who are aware. And so many stakeholders, multi-sectoral stakeholders were convened at that workshop, ranging from people in the operations to all the way to the top elected and traditional leadership. And that's when it all began. So, I mean, in a utopian world, we would have sidewalks and paid hours to exercise while other people did our work and cooked for our families. But we had to start somewhere. So after that, we had to think about what strategies could we kind of begin with and when. And I would have to say that awareness and education was the start of it all. After that workshop, NCD became the buzz. Everybody talked about it. The newly formed coalitions, the overall NCD coalition, the Cancer Coalition then came, I think about a year or 2 years later. NCD was then the talk of the town. So, and then in 2010, with the declaration after PIHOA's resolution, and then Palau's own declaration in 2011, it became even louder. And so every time you see spam, you would go, ooh, NCD. Or, I mean, everything is NCD. There's even a softball team named NCD. So the word NCD can mean something positive or negative, however, whatever context it fell in. So that's awareness and education. There's probably nobody in Palau who doesn't know what NCD is. And then to kind of legitimize everything, even starting in the early 2000s, with when it was still the NCD unit kind of separated, focusing on diabetes, because diabetes program funded that whole unit. There were services provided by that unit and still being offered, where we would partner with some of the offices within Ministry of Health and even community members and provide risk factor assessments. So this would be opportunity samples, because during public events like Independence Day or health fairs, anything that had a crowd, we would go out and we would provide BMI assessments. And then our partners from, say, the tobacco program, Male Heal, Male Health, and then the Office of, Ali, what did you do to my presentation? Then the Office of Nursing, community health centers, they would come with their own screening. So this is something that's been going on for many, many years. The challenge is not all the data being collected is not really consistent, but something that's consistent that we were able to kind of measure is the BMI. So we have the people's ages, gender, and then BMI. And I'll talk about that later. So this was done on top of everything else. I mean, in terms of education and awareness, we would give them BMI measurements, and then we would provide them with a brief advice on nutrition and physical activity. We also, Ministry of Health also consistently promoted physical activity events. They were few and sparse, like walkathons and some aerobics classes. I think in 2006, we produced the first locally made aerobics class or a DVD. So those were the activities back then, 5 years ago even then. And then in 2010, there was just like a swarm of people wanting to exercise. And of course, they would name themselves after the TV show, The Notorious Biggest Loser. So it started off in the workplace, and Ministry of Health provided support. Some of the judges they heard that Ministry of Health had started its own wellness program, and they wanted to do something similar in the judiciary branch. So they called us in to do the initial BMI assessments, and then we provided nutrition education. But they had champions, like a few of the judges took it upon themselves to kind of research on physical activity and even consulted with one of our partners, the National Olympics Committee. And then they developed a program within the judiciary, within the court system. And then, and of course, with the newspapers going on, Koror state government decided to join. And so they called us in for the same support. And then in 2011, the private sector came in. So here we were doing all this work, and people kept calling us to come and BMI us. We want to start our own programs. And so currently, we have about 12 organized groups of people who are doing their own things. And then Ministry of Health supports in terms of BMI assessment and then subsequent weigh-ins after they start their programs. We always advise that they take precaution and see their doctors before they do any strenuous physical activity, of course. It's not just in the workplace, because some of the women's groups within the states and the villages, I think there's three community groups who have joined in the Biggest Loser. After hearing Jennifer talk about evaluation, I'm kind of embarrassed. It's evaluation and data, they consistently challenge us in Palau. And of course, you know that it's expensive and we have limited resources. But I would just like to share some of the things that we were able to do in our efforts to understand our programs and try to improve them. And so, of course, we have the weigh-ins before and after, the biggest losers. I'm just going to call them the biggest loser. And then in 2008 to 2012, August, we had all this BMI data. So making use of our epidemiologist, we told her to just take all the BMI and then maybe try to come up with a story. What do they tell us? So that's another evaluation effort. And then in 2012, we were very fortunate to receive assistance from Pacific Seed, and we were able to conduct focus group discussions with some of these participants. I don't know if you can see that, so I'll just tell you. The BMI, we use the WHO criteria. So for those of you who don't remember, I don't either. But I think it's 18.5 to 24.9, or wait, it's below 18.5, that's underweight, and then healthy weight would be 18.5 to 24.9, and then overweight would be 25 to 29.9, and then anything over 30 and above would be obese. So the green would be the healthy weight. The yellow is overweight, according to my floaties. I think they're floaties. And then the orange or the red is the obese. So to my left, those were the initial assessments taken from May 2012. And this is just an example of one of the workplaces. So if you can see, I don't have my glass, no, I'm just kidding. During the initial assessment, it was a 5% healthy weight. And then after the final weigh-in August, it was 11%. So that's a 6% increase in the healthy weight category. The overweight category, the yellow, remained the same. But of course, the obese category went from 67% obese and decreased to 61%. So there's slight increases in the healthy weight category and then a slight decrease in the overweight or the obese. Once again, the data is not consistent, so I would just take them with precaution. But this is across the board. We see a slight increase in the healthy weight category and a slight decrease in the overweight or the obese category. Now, this is all the data that was collected from 2008 to 2012, August. Again, opportunity sample. What we just wanted to see if there was something going on there. So between those years, we collected a total of, I don't know why there is a difference. That epidemiologist. But I would look at the bottom. There were 2,577 participants, about 44% in the biggest loser or structured, and then 37 and 19% just whoever we encountered in the community or whoever came to our health events or fairs. So looking at all their BMI, and this is the wrong chart. So you're just gonna have to trust me. Because I was supposed to insert the one with the trend lines. So if you look at the green, the healthy bars, is that what you call them? It's supposed to show a slight increase. The trend lines would show you. I swear, look at them. And then with the overweight and the obese, that's the purple and the blue, there is a slight decrease. Don't ask me what percentage and if it was significant, but there was a slight increase in the healthy weight category, and again, a slight decrease in the overweight and obese categories. So it's encouraging, or it's not discouraging. And then with the help from Dr. Mascarenik and Mavis and Jung and Lee and Neil, thank you very much, UH. We were able to conduct the focus group discussions. We randomly selected from the 2,500 or so folks, and we convened them in one of the restaurants. If you buy them food, they'll come. So no, we don't buy food with CDC money. We just rented a good place. Yeah. so, so the focus groups, the goal was to try to identify the strengths of the programs, the three. Remember, it's the biggest loser or the structured, and then the BMI encounters, like in the community or during health events. So we wanted to identify strengths that we could build upon and improve our programs. The questionnaires and guidelines were developed in consultation with Dr. Mascarenik and the UH team. And so we had 6 groups, 4 in the workplaces, mostly in Koror, that's the most populated area, and then 2 community-based groups, one in Koror once again, and then another in Babaltab, that's kind of the rural. These are just some of the main themes that we came across. Most of the participants, when asked if they thought there were benefits, most of them saw the program as beneficial, that they should be in the workplace. It made them feel good. It made them healthier. They felt that motivation was a big factor for participation. They felt that they succeeded more, they would participate more if there was more group support. They needed that. But consistently across the board, and it was kind of surprising for us with all the buzz on NCD, there was a strong expressed need for effective education, is what they told us. There was a need for policies and programs, they said, that support workplace wellness. And this came from the managers also. And then we talked about some of the issues. They felt that the facilities were limited. There were not a lot of places where they could exercise within and outside of the workplace. They were worried that the motivation after it's gone, they would just stop. And some of them said that they thought the wellness approach in the workplace was limited. They wanted to include a more family-oriented, because they thought that if they included the families, then it would take care of some of the barriers, which included family obligations, conflicts of schedules. And then we asked them what we could do to make it more successful. They said that a lot of resources were needed, and for everybody to collaborate, the government agencies and NGOs. So those were some of the things that we found through our focus groups. And so I wanted to take some pictures, but I didn't want to be seen on the road. No. In Palau today, you see a whole lot of people exercising. I mean, people are starting to see exercising or physical activity as not just work. A long time ago, we would just physically move because we were at the taro patch, or we were fishing, or I need to stop. Okay. So definitely, the atmosphere, the social environment has changed. And so for the next steps, an even brighter tomorrow, we need to really improve our monitoring and evaluation, keep the momentum, and push our agenda. Thank you. You should have told me to look at you for the time.
Okay, we do have a little bit of time for some questions, about 10 minutes close to it. Are there any questions for any of the speakers?
Jennifer, I just looked at your data regarding 100,000 meals a day for the public school, 173,000 students.